I know this thing is on, and I know that you can hear me. Nursing and healthcare needs advocates and activism. So what are you waiting for? Let's do the damn thing. Hi, and welcome back to The Gritty Nurse, an unfiltered conversation about healthcare, nursing, and the intersection of health politics and policy. My name is Amie, and I am The Gritty Nurse. This podcast examines hot topics in healthcare and discusses the changes that we need to see to have a more efficient, robust, and ethical healthcare system that is safe not only for the patients that we see, but also for those who work in the system as well. Sorry, no fluff here, just awesome, compassionate humans and a lot of grit. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit that subscribe button so you never miss out on any real stuff from The Gritty Nurse. Every day in Canada, we hear the same story. Surgical backlogs that stretch on for years, emergency rooms shutting down their doors, and millions of people without primary care providers. We tell people continuously that the system is breaking, but what if the solution has been standing in our faces for 50 plus years? In the United States, nurse practitioners are not just helpers, they are the backbone of the system. From CRNAs administering anesthesia in major clinical theaters to NPs running independent practices with full autonomy in the U.S. The U.S. has actually leaned into the full scope of nursing expertise to keep its head above water. But yet here in Canada, we have spent decades tethering our most highly trained nurses to outdating physician-led models, leaving them underutilized while our waitlists continue to grow. Today's guest is here to start poignant conversations about the revolution of nurse practitioners here in Canada and in Ontario. Dr. Michelle Acorn is the CEO of the Nurse Practitioners Association of Ontario. She has held a number of different roles, including the chief nurse of the International Council of Nurses. She's also received the King Charles III Coronation Medal, and she has spent her entire career proving that if you lead as a nurse practitioner, patients stop falling through the cracks. Welcome, Dr. Acorn, to the Gritty Nurse podcast. Thank you so much, Michelle, for coming on the Gritty Nurse podcast. I'm so excited to have you here. The last time we saw each other was ICN, I believe, and I think there was maybe a couple meetings in between, but I'm so glad that you're here to discuss some more about your new role and about nurse practitioners. This is such an exciting time, and I can't wait to hear more. But before we get started, maybe there's some folks out there that don't know who you are. So could you tell us a little bit about yourself and your background?
Sure. Thanks so much for having me, Amie, and congratulations on your podcast success and knowledge translation as well. I'm Michelle Acorn. I am a doctor of nurse practitioner, and we always say, when you say, tell me about yourself, we go professionally, but I'm going to shift and go personally for a minute. I'm married. Some people may know me by Michelle Gray. In my married life, I have 4 adult children, 5 grandchildren as well, and I'm trying to get a life balance. So I'm learning how to golf. I ride a Harley Davidson motorcycle. I love to travel additionally. So that's kind of my personal life. Professionally,
Wow.
I have been a nurse for almost 35 years. Now, hard to believe, I was diploma to baccalaureate prepared, and then on to do my doctorate and postdoctorate work. I have worked across the entire healthcare system, and I identify as a clinician as well as a leader as well. So I'm sure we're going to talk about some of my roles and what we've done right now, but I'm currently the CEO, Chief Executive Officer for the Nurse Practitioners Association of Ontario.
Yes, but you've done a lot of different things. I think that's just, it's like, this is the one role that you've been in, but you've done a lot of different things. Can you maybe talk about some of the other different roles you've kind of dabbled in as well?
Absolutely. It's interesting because my roles, and we define it under domains of practice, which is interesting, and what those dimensions of practice may look like. I was a hospitalized, as I say, institutionalized for almost 30 years as a registered nurse, moving to a nurse practitioner, and actually innovated most of my roles that I practiced in at Lake Ridge Health. So I created most of them, including the first nurse practitioner in the emergency department. As
Wow.
a hospitalist, the GAIN clinics, which are geriatric assessment and intervention network clinics, and then actually the very first nurse practitioner-led hospital from admission to discharge for inpatients. And the other thing I'm so proud about is that's the populations we serve, but it was actually building capacity with my team that really fueled me as well in making a true difference in meaningful access to care within the hospital. After 30 years, I actually transitioned to the very first government chief nursing officer in Ontario that was a nurse practitioner that was clinically practicing.
Wow.
At that point in time. So clinical practice is very relevant to be able to provide the Ministry of Health or long-term care, not just strategic, but technical and operational expertise at the intersection of nursing. So that may be education, regulation, scope of practice, integration across the healthcare system as well. And it's interesting because when we talk about how you practice. I have practiced from the bedside or at the bedside as a bureaucrat to the classroom, as a boardroom, to the boardroom, and locally, provincially, nationally, and globally as well. So the chief nursing officer role was very strategic for me to learn how decisions are made. To learn policy cycles, to learn what works and doesn't work as well. And I did that role for 3 years, actually. And then I transitioned to the International Council of Nurses, as you know, and we connected there as well. I was very proud. I was the inaugural chief nurse for the International Council of Nurses, so representing the 29 million nurses in the world across high, middle, and low-income countries, everything about education, regulation, safety, universal health care, and partnering with the World Health Organization, the United Nations, such as the Commission for the Status of Women for Gender Equity as well. And really, it's actually partnering with the National Nursing Associations. And I think there's over 140 of them at that point in time. And our member of interest is the Canadian Nurses Association as well, which I'm a strong member and fellow as well. And then the last 2 years, I've come back home, and I was headquarters were in Geneva, Switzerland, by the way, but for ICN, but during COVID, of course, prevented travel. And now I'm back in Ontario, and I have a mandate to represent the 6,000 nearly nurse practitioners in Ontario, which, by the way, are more than 50% across Canada, what we'll talk about. And now we're really trying to utilize this as thought leaders to ensure we're integrated in the healthcare sectors and academic sectors and socioeconomic sectors, and to ensure our voices are vital, valued, and representative across our healthcare system.
Well, there could not be a better person in place for that role. Like, wow.
Thank you.
I knew you were cool, but now I know you're like really, really cool. Yeah, no, that's such an amazing journey. And I think that it's such a shining example to other nurses, just how eclectic our backgrounds can be and how far and wide we can go with nursing. Because again, I feel there still are some nurses that feel that they can be stuck in their careers or feel that they can't, traverse. And you just pretty much have been literally around the world in nursing. And it's so inspiring to hear all of the great work that you've been doing. But today we're going to talk about nurse practitioners specifically in Canada and in Ontario. There's always some confusion surrounding the role of a nurse practitioner. And I think it's important that maybe we talk about language and terms. Do you mind describing what a nurse practitioner does today?
Absolutely. There is confusion, but it's interesting because I do want to kind of just go back a little bit, as nurse practitioners have been here for over 50 years in Canada. And we work really hard at public education and professional education. But I want to share with you the newest definition of nurse practitioner from the Nurse Practitioner Association of Canada. I think it will really resonate. And it's a nurse practitioner is highly educated and healthcare professional with foundational training and education in nursing. They play a unique but complementary role in the healthcare system, practicing autonomously while integrating advanced clinical knowledge, diagnostic skills, and specialized expertise. They are qualified to diagnose, treat, and manage a wide range of health conditions from minor ailments to complex illnesses. We're rooted in whole person, patient-centered care. Nurse practitioners consider the social determinants of health to provide comprehensive and individualized patient care, and their practice reflects both their nursing background and advanced medical knowledge, allowing them to effectively meet diverse patient needs. That's the definition, but we need an elevator pitch and a latte chat to make it really, really, really go. But I think that's really different in terms of really grounding what we do. We bring our expertise as a registered nurse for many, many years and our baccalaureate training. Then we utilize our graduate, or many actually have doctoral preparation. Basically, we are your solution to access to care and as well as decision-making tables and policy making. And we can practice anywhere. There are very few limitations. I think we need to ensure that when we talk about language and maybe making it relevant to Ontario right now is the mandate for the primary care access team. And if you'd like to do a deep dive, we can make it relevant that way.
I think we should do a deep dive.
Okay.
I think it's important that we have this conversation. It's so timely in terms of, how many people do not have primary care providers. The fact that nurse practitioners like you said, nurse practitioners have been here for 50 years. And I think that the medical model has been drumming along in this system. And we have to make recognition when things just aren't working. And if the end solution and the end goal is patient satisfaction, patient care, that everybody gets to be seen by a care provider, then why are nurse practitioners not a part of that solution? And I'm going to hand it back to you because I know that you have more to say.
Well, I think we need to shift the mental model, Amie, and really challenges status quo and be disruptive innovators. And that's what NPs are. You get the value add investment. If you leverage us as clinicians, leaders, educators, quality improvers, and change makers right now. But here's an example in Ontario. You have almost 2.5 million people that do not have access to a primary care provider or clinician. And I say those words deliberately, intentionally, and purposefully. 100%, $2 billion have been invested, and I applaud the Ontario government on that. It's been invested for attachment to a nurse practitioner or a physician. 100%. And I think that is really important right now because really before it was attached to a family doctor and now it's attached to either or, plus being leveraged and supported by their interprofessional teams right now. The landscape in Ontario looks like we actually, in 2007, I don't know if you remember this, Amie, nurse practitioner-led clinics opened up in Ontario. We only have 27 still to this date. And I think we need to kind of talk about what that looks like. And it's a nursing talk and for nurse practitioners as well. But I want to share that because nurse practitioner-led clinics in this expansion of interest for primary care right now are one of the models of care, which, by the way, nurse practitioners are the most responsible providers. They're leveraged by a full team, RNs, RPNs, pharmacists, physiotherapists, social workers as well. But what's sentinel is actually the governance model. It's the lead as a nurse practitioner, not just as a clinician, but also 51% of the board are nurse practitioners.
Yeah.
That is for model of care and decision making.
Yeah. So how do we get to the point where people truly understand? And I think this is where we have, maybe I'll actually back it up. I want to go back to the fact that, we have almost 6,000 nurse practitioners here representing in Ontario. What is the biggest hidden contribution you think that currently they're making in the system that the public still doesn't see? Because I think a part of understanding is the public has to truly understand what they did. The description is very clear, but there still is this discrepancy between, the public understanding the quality and really, truly the expertise that nurse practitioners bring to the table. So what do you think the biggest hidden contribution is that, the public doesn't see?
That's a difficult question. I've been thinking about this more and more because as we continue to educate in campaigns, there's a lot of nurse practitioners right now. We know nurses are trusted year after year, and nurse practitioners always leverage the nursing and trust. So they do know that. But sometimes it's actually the identity of the nurse practitioners and what that looks like. I think that evidence speaks to a lot of the role, but sometimes the public doesn't care about that. And I don't say that in a disrespectful way. They just want a meaningful experience, and they want someone who can see them, that is competent when they need to be seen, and meet them where they're at. And that
Right.
is the lived reality. Nurse practitioners, by the way, are the most evidenced, researched professional out there in the healthcare space. I'm not sure if you're aware of that. Tried, true, and tested, safe, efficient, great patient experience. So our public, our citizens that interact with us, they know that that is the case as well. They tend to think, I think the public thinks, us think, what can they do for us?
Right.
So I think we need to think, okay, what does this matter across? So nurse practitioners can care for you across the entire health life cycle, from birth, unfortunately, to death. All stages, all sectors. Nurse practitioners are in primary care in the community, in long-term care, in every correctional facility across Ontario. Did you know that as well?
I did it.
For health equity seeking populations. They can do assessment. They can do diagnosis. They can broadly prescribe medications for all your health promotion and health prevention needs. They can assess and provide medical assistance in dying and palliative care. All your diagnostics, CAT scans, MRIs, for example, ultrasound. That's how people think about us. They can help you in your lifestyle management and counseling, your chronic diseases, mental health illnesses, high blood pressure, cholesterol. They can do all of that. They can admit, treat, and discharge from hospitals and long-term care. And soon, with some of the new policies coming through the government, they can actually be clinical medical directors again in long-term care, which happened during COVID. So people do understand that piece of it, but I think that it's the language that perpetuates. So their primary care provider is a nurse practitioner. It could be a doctor as well, or they can do shared care. It's what the model of care looks like and how they experience it.
So what would you say is the biggest barrier then, Michelle? Because again, if the fact that there are, out of all of, I think it was all of Canada, you said that there was only 27 nurse practitioner-led clinics?
Yes.
That's a problem. Why don't we see nurse practitioners more widely speaking? What do you think is the biggest barrier?
The number one barrier to full access to care to a nurse practitioner, so you can realize your full health potential, is actually investments in funding, frankly. So, and we can kind of talk about that a little bit more, but there's other models of care in primary care that are being funded right now through the primary care access team. And that could be through community health centers. It could be through family health teams and Indigenous health centers as well. So those are the models that most people realize. However, the tides are changing, Amie. And I don't know if you know that, because I'm sure you do, but others, right now, we're at the private-public intersection of care because people do not have access to the care they need. And some people do not have the abilities to pay, and other people do. So some of our nurse practitioners have gone into solo private practices as a result of need, not greed, because there's no funding to actually remunerate them for the care that they are doing right now. And that is the lived reality. So when you ask, what is the barrier? Why don't people know about us? It's because of actually funding and how the models of care are set up for the conditions for the nurse practitioners to thrive, to deliver care to the public.
So let's get into that. Like one of the questions that I keep on seeing is really relation to funding and as well as the models. Let's maybe talk about the funding aspect. What is it that nurse practitioners need from a funding or, from a funding perspective that might help support a more nurse practitioner led, I guess it would be like care models within Canada and Ontario as well?
Right. The only funding that is existing right now through the ministry, and we do applaud them for that funding, however, we still need some significant more, is the only thing is salaried models of care. So you would be working as an employee, and as I mentioned, all the areas that they practice in. However, we worked very hard with many associations and many nursing leaders across the province in Canada to challenge the Canada Health Act. And the Canada Health Act, actually, the former Minister Holland, we worked closely with as well, who released the interpretation letter that nurse practitioner services that are medically necessary should be publicly funded by April 1st, 2026. So we are not far off. This is Sentinel right now. Talks about universal health care. The only way you can see a nurse practitioner at this point in time is if it's a salaried model funded by the government, and there's only pockets of time where these expansions of interests are able to be funded right now, and the same models of care are going to happen. So what happens now is that we're working very closely on advocating and partnering with the government for flexible funding models. And what does that translate into? That translates into nurse practitioners should have financial autonomy like we have professional autonomy.
Right.
And our scope of practice and the way we want to practice and enjoy similar to our physician colleagues. And that could be agnostic in how that looks. So that could be a salaried model where you're an employee. That could be a blended capitation model based on the populations you're caring for, or it could be a nurse practitioner schedule of benefits. Some people think automatically April 1st, nurse practitioners are going to be able to bill similar to physicians, but
Right.
that actually has not actually been established here in Ontario as well. And we should have the mandate, and our North Star should say nobody should be left behind based on their inability to pay. So April 1st, NPs need to have those conditions in place to reimburse them. Unfortunately, Ontario's behind in flexible funding models. So our colleagues in nurse practitioners in the West, for example, BC and Alberta, have established some direct reimbursement models with the government and with the nurse practitioners as a provider, as well as some in the East right now. We need to catch up so that we can utilize nurse practitioners. CIHI, the Canadian Institute for Health, they established nurse practitioners are the most expanding nursing category. And we are increasing by 10% per year. Do the math. But we have nurse practitioners that are underemployed, underutilized, not working full scope of practice because of some of their working conditions that are providing structural barriers to that. And we have an opportunity to expand education seats and, more importantly, full value add for access to care. And we have solutions that are very tangible. Why aren't we moving on them faster?
I agree. And I think that leads right into talking about the models of care, right? And seeing how we can expand the role of the NP and use nurse practitioners to their full scope. Just, it begs the question again, like, let's just go talk about the models of care. Like, what is it that you're seeing, Michelle?
Well, the models of care right now, are not harmonized across the sectors. So there's a lot of the politics and the policy, the big P's and the little P's, as I talk about right now. But why are nurse practitioners not being utilized? With what funding is available right now, it's not just funding, it's compensation. So we do not have, if we want professional parity or professional equity, and let's call what it is, it's gender equity in a highly female-dominated profession, and nurse practitioners as well. We're not realizing the same reimbursement equity of what that looks like. Did you know that in primary care, and our colleagues, primary care is the foundation of healthcare right now, that they are remunerated less than in hospitals and long-term care? And this isn't just nurse practitioners, it's their entire healthcare primary care teams. So if we can't stabilize and invest in primary care and ensure that we're paying people responsibly for their accountabilities to not just recruit them, but more importantly, retain them, that is a huge issue. You could go work in the hospital and you're actually receiving up to $30,000 more.
Wow.
In a hospital, it's not just money, it's the conditions of work and nothing that's going to restrict your practice. But that is a huge one. Now, the ministry did enjoy and announced a small increase in primary care that I do applaud. However, we have a significant way to go, and we need to really stop this wage gap because it was only 2.7%, by the way, which does not keep pace within Ontario. But the other bigger thing is it doesn't keep pace with Canada. So we don't just have sectors to worry about now and stabilizing the sectors to harmonize it. We have to think about pan-Canadian, how they can actually move to other provinces and territories as well. And I think we need to think about that additionally. So the other piece is how funding happens. So it's interesting. So the employee situation for nurse practitioners, a good example being primary care, the money goes to the employer. The employer doesn't necessarily have to give the same amount of money to the nurse practitioner. So when I talk about financial autonomy, and this is the same for other healthcare workers as well, not just nurse practitioners, but I think the solution is dedicated, protected, enveloped money for nurse practitioners that is separate than the allied pot of money as well. And that happens in hospitals as well, because if nurse practitioners are in hospitals, they're your most responsible provider. That impacts the cost per weighted case. That doesn't for physicians. And then that actually creates funding disequity in the future.
See, I think I would say I didn't even know half of that. And I think that's really important for people that are within the advocacy space to understand, what are some of the challenges? What are some of the things that we can leverage? What are some of the conversations that we need to be having in relation to seeing, nurse practitioners being compensated properly, fully used to their full scope of practice, and that actualization that, they are independent members who can provide a service that we desperately need. I don't understand. We continue talking about the back end, right? So particularly about like emergency medicine, wait times and all these things. And we don't talk about primary care nearly enough. And it's very bizarre to me that we are kind of underfunding primary care. And again, I've heard the same challenges from, other peers and other people in the primary care space that just staying there is not worth it. The work is not worth it. And the amount of work is not worth it. Again, where you've mentioned that, they would rather go work in hospitals because the compensation's better and, maybe the workload is different as well. So again, I think this is just a really topical and timely conversation so people can understand where some of these gaps are and continue to, talk to our governments and our politicians and decision makers about how we can kind of mobilize and move the needle in a direction that actually works for health for all people. And we need to have a better, I guess, like community-based healthcare, where we're not so reactionary, where we're not just saying, okay, well, here's the emergency department suffering. Primary care is on fire too. So if we're going to look at models of care and we're going to look at funding structures and we're going to look at how we can change the system, we really need to look at nurse practitioners and how they can provide answers to some of the challenges that we see. As a CEO, in terms of this year, 2026, what would you say is one of your top priorities? How can nurse practitioners not just be included in the system, but lead it?
Absolutely. It's recruitment, retention, and respect, the 3 R's. And we talk about the 2 R's, recruitment and retention, but it's not respect. Because if
That's
respect is, and, Minister Carney actually just talked about it. If you're not at the table, you're the dinner and you're on the menu. Yep. I always say that all the time right now. So we talk about diversity, equity, inclusion, and that's also part professional as well. If we're not actually at these decision-making tables, I think this is key. Like we are looking at being part of the Ontario health teams right now and nurse practitioners co-leading primary care networks in Ontario right now. But the number one thing that we need is flexible funding so that we can work and have our shingle up today in whatever manner we want to work at or with the populations and get paid for that today.
Yeah, no, right? I think
that is the stability piece about it for nurse practitioners. It's not that they don't want to do the work. They are committed. So many people are staying and they just are so upset about leaving primary care, but they can actually pay their own bills at home and support their families based on that, or they're doing so many long hours. Nurse practitioners have administrative burden, similarly to our physician colleagues as well, but the incentivization is very different and that value piece as well. I didn't share earlier, I still clinically practice as well. And these are the things I need to do that. It fuels me. It keeps me more relevant. Right now, I actually look after young offenders that are in custody at the intersection of health and justice and human trafficked and exploited youth.
Wow.
Additionally, right now, and again, without these dedicated funding, we can't do these things, but we do it because we don't want to leave anyone behind.
Right.
And I think we need to think about these things. And, you've talked about this as well. What are the conditions? Did you know the next condition when we talk about is respect is actually data and attachment, Amie? That is the next condition. So how would you like to have your nurse practitioner being your most responsible provider, or you're attached to a nurse practitioner and the ministry, the government of Ontario doesn't actually know about us and collect that data similar to our valued physician colleagues?
Right.
So actually, more than 2 million people are attached to nurse practitioners, but only some of the models of care they're starting to get some information on, like NP-like clinics or community health centers. How would that make you feel as a professional if your work is invisible
Right.
or it looks like they're attached to a physician, but you're actually doing the work because of the models of care and how they're funded through the ministry or rostering and things like that. It's not
Yeah.
intentional or deliberate. It's how it's longstanding, traditionally deep-rooted things. But this is if we're going to change the forefront of what that looks like in accountability and transparency. This needs to move forward.
I agree. And I think, I mean, you were asking me directly, like if I was in that position, how it would make me feel quite undervalued for the work that I'd be doing. And I think that at the end of the day, nurse practitioners have so much value that they bring to their role. And again, we shouldn't have to be begging. And this is where we have to continue to educate and inform and let people know not just what is being done, but the level of expertise, clinical value, how we can reduce, wait times if we're actually put into these roles and operationalize the way that we actually should be, and that is through the recruitment, retention, and respect of the nurse practitioner profession. One of the things I wanted to ask you about is also some of the global work that you've done. What is one of the global ideas that you have most determined to take on to localize here in Canada in relation to nurse practitioners?
Well, it's interesting. You go back to what's called the World Health Organization has what's called the Strategic Directions for Nursing Midwifery on a high level. It's this policy document. And I'd like to bring it back down to grassroots. So Canada is a state actor, and Canada agreed to it as well as all the state actors. So it looks at leadership, education, service delivery, and I don't like the name, but jobs. And that's how it
Right.
roots nursing. Part of the solution in the strategic directions is advanced practice and nurse practitioners as well. We need to leverage nurse practitioners. They are well educated. We actually have a ICN, Advanced Practice Network, Nurse Practitioner Network as well. And we connect on the global stage, but it's universal healthcare. It's really enabling all the professions and not holding anybody back. Boundary work and scoping together is a good thing. Actually, many of us can complement one another. It's safety and it's improved access. So I truly believe that nurse practitioners can be there not just as clinicians delivering universal health care to all populations, including those that are underrepresented, marginalized. I don't like that word. Vulnerable as well, and rural and remote areas, and the complex patients that a lot of people don't take on because it takes a lot of time.
Right.
But they're also leaders. They can be actually in the universities, in government, with the associations, with the regulators, and really influencing this. And it really comes back to talking about the quads. And that's the intersection of how NPs are integrated with all the unions and employers or self-employed and showing that system through that. So I do believe, honestly, that nurse practitioners, and this is probably where I'll end my career and retire one day, they are the solution. And it's been my most rewarding professional trajectory because I like to uphold all the areas. And if I'm here as CEO today, you can see I still think as a clinician. I think about the scholarly evidence. And our mandate is to ensure we leave no one behind. And that's patients. And now that's the profession as well.
I think I'm trying to think of the right way to kind of formulate this, but I think it was so clear and succinct in terms of how people should understand. And again, I really hope that politicians listen to this episode because I know there's a little bit of a disconnect because I had some conversations with some other health leaders in nursing. And when they were talking to some politicians about understanding the roles of nurse practitioners and what nurse practitioners can really truly bring to Canadian healthcare. And I feel like I really hope that we get some folks that listen to this podcast episode because there's so much here that you've discussed, so many things that I didn't even know that are enlightening to me in terms of my own advocacy journey, in terms of talking about nurse practitioners and really just understanding the pivotal space that nurse practitioners take up. I think it's so important that we do take up space and that I truly do see a future that nurse practitioners will be utilized in the way that they can. It might take some time, but I truly believe that we'll get there. Is there anything that we haven't discussed in relation to nurse practitioners and, seeing a newer model of healthcare that involves one, not leaving anybody behind and truly fully using nurse practitioners to their full extent?
It's interesting. And I think I'll share the strategy. in the last 2 years is really nourishing relationships with government and external partners right now. I have to tell you, NPAO has been very, very strong with this. And we have a good relationship with government, with the minister, the deputy minister, for example, our assistant deputy minister and chief nurse as well. And I think that's key because you can be there not just as an advocate. Remember, before I was a bureaucrat talking about intentional and unintentional consequences of no decision of policy or moving forward policy. Now we can be there as thought experts and share data and work together as partners. And we've really enjoyed that right now. However, we have to really continue to move that needle in terms of what that looks like, how we can be solutions, but at the same time, set the pulse on what people will tolerate and not tolerate. And I think that's really important right now because, the dynamics of power and sometimes how you continue to work on respectful relationships, we have done very well in that. And we refuse to actually stoop low. We want to go forward with facts, patient stories, and professionals. And I think that is key for nurse practitioners right now. We're partners in your health, we're partners in your care, and we do care, but also we will not be disrespected.
Yeah, no, I think that's powerful. And I think you're right. When we do talk about the various different powers that there are, whether it's in the political realm or in the healthcare space, that it's important that we do respect each other's, disciplines and areas of expertise, and that no one particular profession, and again, I'm speaking specifically to nurse practitioners, should ever be disrespected. And that again, they are strong partners within the care that they provide. And you're right, using the evidence, using the stories, because patient stories are powerful in terms about talking about change and how we can, again, I'd say move forward together in improving healthcare for all Canadians. Because at the end of the day, that's what it really truly should be about. It shouldn't be about, positionality, hierarchy, or these different things. It really should be about how can we deliver the best quality care to patients and families all across Canada? And that is involving nurse practitioners in those care models as well. I stand firmly with you, Michelle, in terms of the belief that nurse practitioners have a huge role to play here in Canada, and we have not yet reached the pinnacle of that role. And I hope that we see expanded roles in nurse practitioners as well. We haven't touched on it today, but knowing that there were nurse practitioners that left Canada to do like nurse anesthesia in other places, I feel like there are still room and opportunities for nurse practitioners to continue to expand and to do more work here. So this conversation is far from done. And I hope that we'll continue having more conversations about the great work that nurse practitioners do across Canada. And we have to stay connected because I'm sure you'll be doing more things. So proud of you, Michelle, and proud to, call you a friend as well. So thank you so much for coming on the Gritty Nurse podcast. And before we go, anything that we have not touched on that you'd like to touch on?
A couple of things, but time is essential. But we are going to a 1NP registration across Canada right now, so it'll be harmonized.
Wow.
I think that's really important. So when you talk about how we leverage nurse practitioners, do they have the knowledge, skill, and judgment? So we had NPs that did NP anesthesia, for example. We have CRNAs, as you talk about. So, you know what? We do have a solution to actually reduce wait times or surgical care or pain management and things like that as well. So we don't have to perpetuate the same models of care. So I want to talk about that. And there's a few things for scope of practice. And, is political will, legislation and regulation that needs to change right now, such as the Mental Health Act. If we're your most responsible provider or you're attached to us and we can't do a mental health form one or in hospitals, that's a barrier to access to care or knowing those few nuances. We remove most of them and that's key. I kind of like this quote and I hope you don't mind. I always we talk about investing and we talk about money. But when people are financially invested, they want a return. When people are emotionally invested, they want to contribute. And that's from Simon Sinek. And I truly believe in that. Nurse practitioners are invested. They're invested in your health. They're invested in the profession. And let's not lose them. Let's really harness their full abilities and invest in them because they are here for generations to come. And the sky is the limit.
I completely agree, Michelle. And I think that, like I said, this conversation isn't done yet. There's going to be many more conversations that we have in relation to nurse practitioners and the absolute power that nurse practitioners should have in terms of being able to, provide care for Canadians all across Canada. And I'm looking forward to seeing some of the work that the NPAO will do as well, and some of the work that you'll do too, Michelle. So thank you so much for coming on the Green Nurse podcast. We'll probably have to have you come back to talk about, again, we don't want to have the brain drain of practitioners leaving Canada and Ontario to go to other places because, there aren't models of care that help support their practice here. So we'll have to have you back on to have that conversation as well. But thank you so much for taking the time today. And, it was such a wealth of information. I hope lots of people will have something to take away from this conversation.
Well, thank you so much for the opportunity, Amie. And April 1st, 2026, we should have a lot to talk about by then.
Yes, I have it down here, the April 1st milestone. So let's see what happens. I can't wait to hear. Absolutely. We'll have to have a conversation after that.
Thanks. Stay gritty.
I will. You too. Looking for a great gift for a nurse or someone who needs to learn about nursing? Check out my national best-selling book, The Wisdom of Nurses, Stories of Grit from the Bedside. Thank you so much for listening to The Gritty Nurse with Amie Archibald-Varley. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit the subscribe button so you'll never miss out on any awesome episodes from The Gritty Nurse. Thank you so much and stay tuned until next time. Stay gritty.